You guys still hearing me okay? Okay, about 20 million Americans, and only about a quarter of those, actually less than a quarter, about 4 million, which is about 19% of those actually get treatment for it. It is true that, you know, they say 74% of those struggle with alcohol use disorder, but almost 40% struggle with other kinds of drugs, both prescription drugs and also street drugs. Polysubstance, though, is probably the most common of all. And as you notice, 74 and 38 don't add up to 100, and so there's a lot of co-occurring use, which we'll talk about in just a second. Of that 20 million, about 2 million have an opioid use disorder. Now we're focusing down on what we're really going to talk about today, and that corresponds to about, you know, close to 1% of the population, about 0.7, and that's a 2018 figure. It does vacillate a little bit, but it hasn't changed that much. And that opioid use disorder includes all forms of opiates, whether they're prescription, legal, illegal, whether they're smoked, inhaled, injected, or whatever. Whether it's heroin or oxycodone, it includes, those are the opiates we're talking about. The public health concerns, you guys yourselves are probably the experts in the public health concerns. You know the sort of problems that it causes. And the two I want to concentrate on, above and beyond the disease and the physical complications that go with substance with heavy opiate use. The main ones I want to talk about are child abuse and neglect. And partly the reason why substance use has such an effect on parenting is in that reward circuitry that we were talking about, the thing that addiction hijacks, that reward circuitry was designed to enhance and compel the relationship between parents and children. And so by hijacking that reward system that's meant for interpersonal kinds of behaviors, it sort of disarms some of the compelling feeling that people have about taking care of their kids. And so it can greatly impair parenting in that respect. And then also the other thing I want to say is that it is associated with criminality, and by criminality I'm talking about everything. You know, I'm not talking about, you know, high-speed car chases and armed robberies necessarily, but I am talking about even, you know, minor and major kinds of criminality. And like Dr. Shi and I have, you know, probably spend most of our time treating individuals who have some sort of legal complications, and substance use addiction almost always goes along with that. It promotes it. It's not like everyone with substance abuse commits crimes, but pretty much everyone who has a problem with criminal behavior is oftentimes using substances. Retrospective view is important on that. There are, you know, I just put gateway in quotes because I don't use that word very much. It's not a particularly useful word, although there is some truth to it. There are drugs that people tend to start with, and they do tend to progress. And everyone knows, at least somebody has some patient or friend or someone who said that the first time they used a particular drug, it's usually, you know, it's usually cocaine or heroin or meth. They felt like that was what they were looking for. They feel like it was an instant addiction. But for the most part, the individuals who progress from use to abuse to addiction are those that already have high risk. And it's the risk that I want to talk about. So it's, if you already have the high risk, yes, there's a high risk of progression. The most common figure you're going to look at when they're talking about genetics is they say for about, notice the terminology here, about 40 to 60% of a person's addiction I'm always suspicious of terms like 40 to 60, you know what I mean? Because it's not very exact. And the point is, of that genetic risk, it's the sort of risk early childhood experiences on gene expressions. So it's not really what you inherit from your parents mainly, it's mainly how your genes are changed. And they call that epigenetics, how your genes are changed by early childhood experiences and by using drugs themselves. And so that's really where the issue is. No one just flat out, inherits an addiction. You might inherit in your chromosomally, you might inherit some propensity to have more reward or greater response to certain medicines. But for the most part, it's early life experience that makes the difference. So that the idea of whether it's nature or nurture is not really relevant, and it hasn't been for a while. Most of those early adversities that children experience are now wrapped up in what we call adverse childhood experiences. Now, I know I'm just going to breeze past this, but I want to make the point that adverse childhood experiences, which can promote anything from anxiety, depression to heart disease. One of the things that adverse childhood experiences are most selectively and uniquely influence is the risk for substance abuse. And if you look at this very common graph, this is on the website. They have all sorts of websites on the Adverse Childhood Experience CDC website. But you can see that relationship between early adversity and the numbers of adverse experiences you have gradually is stepwise linked to your risk for alcohol abuse. But notice there's two bars there. I want to point that out, that the pink bar is the one that it's just the relationship to adverse experiences. The green bar is those adverse experiences plus having parents who have problems with alcohol. So it's like anything else, these risk factors are always added to destiny.
Dr. Davis, we have a question in the chat. I'm not sure if you want to address the questions at the end or if you want to do it now.
Leslie, I'm going to wait till the end because I want to make sure I finish to give Dr. Shi adequate time. Is that acceptable?
Sure.
Okay. So adverse childhood experiences and substance use disorders, like I said, are linked, uniquely linked to IV drug use for some reason, probably because IV drug use is usually, but not always, opiates. But there's even a stronger relationship. And so if you get to the number as adverse experiences, meaning 0, none at all, or 1 or 2 or 3, it's stepwise linked to a higher risk for IV drug use. And it's about 3 times, when you get up to numbers of 4, it's about 3 or 4 times as common. No, I take it back. It's more like 5 times as common. But if you get all the way up to 5 or 6 or 7 or 8 adverse experiences out of the 10 that are officially listed, the chances for IV drug use are 46 times as high, 4,600 times as high. What medication-assisted treatment is trying to do for substance use is to somehow address the brain problems that go with substance use. And like I said, using substances does change your brain, and the attempt for medically assisted treatment is to somehow neutralize that effect on the brain and get a person to the point where that the risk and the compulsion is better managed. And the way it does this, for the most part, a broad meaning of medication-assisted treatment would be just treating any co-occurring disorder, like with antidepressants, antabuse for alcohol, acamprosate, which is Campro. that is the broad meaning, but what we're really talking about here is the use of medication-assisted treatment for opiates. In that case, it's usually some mixture of agonists and antagonists. Agonists are those medications which promote or excite a neurotransmitter receptor, and antagonists are those that block it. And it's the combination of those that is usually the attempt to manage addiction. The medications that are used in that are usually these four are similar. Methadone, never rule out methadone. It's less convenient because you have to go to a specific methadone site to get it. But it is also a mainstay and a very effective mainstay of medication-assisted treatment. Buprenorphine is what's more common at this point. That's what you're going to find as the main component of Suboxone, for example. Specifically about Suboxone right on the next slide. Buprenorphine is an agonist. It's something that calms down that craving by partially satisfying it. Naltrexone, on the other hand, and naloxone, both of those are those block the opiate receptors, and it's the combination of those and the careful use of those that gets a person into that middle ground where instead of craving or withdrawing, they feel normal, which is the goal of medication-assisted therapy. Naloxone, you all know, that's Narcan. And Narcan obviously is an antagonist. It's for the emergency intervention in an overdose. Suboxone itself is a combination of buprenorphine. It's in a 4-to-1 ratio. Buprenorphine is an agonist, so it is an opiate of a kind. It's an opiate agonist, and that is what partially satisfies the craving and eventually eliminates the drug seeking that's so powerful in opiate use. The naloxone, on the other hand, is an antagonist, and when combined in a very careful mixture, it is something that prevents overdose and also prevents much abuse. The fact is that there is Suboxone. It's one of the arguments that people will make about it. But there's very little diversion or abuse for the purposes of the euphoria. It's not a great drug to abuse. It relieves the withdrawal, and most of the diversion is in order to relieve withdrawal symptoms, not for the high that goes with it. And like I said, it can be prescribed as an outpatient. It takes a special, every prescriber has a license from the New Mexico Pharmacy Board, and this takes an additional license with the pharmacy board and with the federal government in order to prescribe it. It's not because it's so fantastically dangerous. They just want people using it right. Here's the arguments for and against. I just want to say something about them. Opiate replacement therapy. My notes, and so I actually use my notes for a change here. For one thing, opiate replacement therapy, which is the same thing as medication-assisted therapy, it's not an experimental use. It's well tested, and it's well known to be effective and more effective than the alternatives. It's a maintenance medicine, and it's not like taking a drug. It is more like taking a chronic medication in order to control a chronic disease. A lot of patients will stay at the same dose, like Suboxone, for many years or permanently. And most important of all, there's not physical or psychological impairment when the dose is carefully managed, when the induction or the start of the medicine happens well, What it does is send a person, like I said, back to a normal state where craving doesn't consume their waking hours. It's not a new addiction, which is something that some people will worry about. It isn't an addiction, but it is a controlled substance. Is it available? You know, these are old figures, but it's not as available as it needs to. There was a point at which only half of the privately funded substance use offered medication-assisted treatment, and then even at those, of them were actually had most of their opiate-using patients on it. So it's not as used as it should be. However, it's true that between 2014 and 2018, Medicaid spent 176% more on the medication-assisted drugs than they had before. So there's been, there's been a fourfold increase over a number of years, and the number of patients getting it increased during that same time period by 9%. And so the increase is coming, but it's slow, frankly. Every talk is going to tell you that simply doing one particular treatment is not going to be effective. It has to be a full range of treatments, including vocational family services, medical, other kinds of medical services. That's the only way in which treatments really proceed, is when they're combined like that. But I will say that these are two articles that I put on, and I put the link on there so that you can look at them, because they're quite helpful, and also they're free. It's look hard to find which ones are put out by NIDA or which ones are free from the U.S. government. This one talked about combining treatments, just like I said, that behavioral interventions, meaning cognitive behavioral therapy, even there's various kinds of behavioral interventions, most of which are counseling. They have about an 80% relapse rate, which, you know what I mean, that sounds like fantastically high, but I will say that there's 20% of people that do make it on that alone. You get similar poor results when you just do detox and then send a person out again. It has to be somehow the craving has to be reduced and behaviors have to be changed. And this is my last slide. What this basically is talking about, this is actually talking about methadone. And methadone does do this, as well as Suboxone does this. With prolonged use, some of those brain changes actually begin to come back to normal. And you can see it. You can see it with imaging. You can see it in neurotransmitter levels. You can see it in behavioral changes. But with prolonged use, and the long-term benefits usually, she may talk more about that, but a lot of the recommendations are that a person should plan on being on medication-assisted therapy for probably 12 months at the beginning. And some people stay on it permanently. So I'm going to turn it over to Dr. Shi. And you want me to unshare this?
Well, thank you, George. Let's see, I don't know if I have the ability to share a screen or not from this point. So
you want me to?
If you don't mind, maybe perhaps sharing your screen, and we'll just have you advance slides. That would be maybe
okay.
Easier. Thank you. Well, while we're setting things up, I want to say thank you to Dr. Davis and to Leslie Jones and the ECHO program for inviting me to speak. I come to you with clinical expertise in delivering medication-assisted treatment. As a primary care pediatrician, I had not anticipated becoming a provider of medication-assisted treatment, But in my work with families affected by substance use disorder and trying to think about how to take care of children, young children who had exposure, I realized that it was very difficult to help those children stay well unless we're willing to also address the health of the parents, which included their needs for opioid replacement therapy. So I obtained my exception license and now prescribe medication-assisted treatment as part of our outpatient program. I want to tell you a story about a typical patient that we see in Adobe, Antonio, who is at 17, coming to the Adobe program, released from the Bernalillo County Detention Center. And Antonio entered the detention center with a history of shoplifting, breaking and entering, and so became incarcerated. While he was there, he met with one of our navigators, a community health worker that we hired for the Adobe program, who presented the program to him, helped him decide whether or not that would be useful to him. And then before he was released, made appointments for Antonio to come to our primary care clinic so that upon release, he and his family knew exactly how the safety net would operate to continue care. So Antonio came to his first clinic appointment with us 5 days after release. And in that clinic appointment, he disclosed a substance use disorder history. And that use included heroin the day prior to appointment, the use of methamphetamine daily since release, and the use of marijuana multiple times a day. So while he didn't have access to drugs during his incarceration, the period of release kind of returned him back to an environmental situation where he could restart using. And that's part of the reason that when people are incarcerated for long periods of time who have an opioid use disorder and do not have access to replacement therapy, why their risk for overdosing is so increased. And so people who are incarcerated over a long period of time have a much greater risk of overdosing because the amount of heroin they were using prior to incarceration, if they use the same amount after they're released, may encounter an opioid receptor system in their brain that has become regulated and normal, and thus much more sensitive to opiates. So on the next slide, we want to talk about how we have begun to organize a consult for Antonio. Dr. Davis, could you advance the slide, please?
I'm having a little trouble doing that for some reason. I don't know why.
Well, technology is a wonderful thing when it works. And
it hasn't happened today that never has happened before.
It just adds to the story, right? I mean,
I know it does. I'm going to stop sharing and bring it back up again.
Okay. These presentations would be very, very standard if they all worked the same, but since they always have these little quirks built in, they become hopefully more memorable, hopefully memorable for the right reason. But to continue the story, we learned that Antonio has access to buprenorphine, which remember is a combination of buprenorphine and naloxone. He's accessed it from street sources, so he's not ever had it prescribed. And he really feels like it hasn't worked. But he also reports that he's taken it episodically. So he might go for a period of time where he doesn't have access to heroin, and then he feels like he's withdrawing, and he gets access to Suboxone, so he takes it to prevent withdrawal. But taken that way, it's potentially not very helpful. It's not likely he will overdose from taking it that way, but it's certainly not going to move him toward a healthier direction. He's had brief contact with counseling services as part of his terms of probation, but as Dr. Davis mentioned, people who only have counseling often continue to have a high risk of ongoing substance use disorder. He also has a history of anxiety, sleep problems, and possible depression. He was given an antidepressant while in detention, which was great. He felt better, but as soon as he got out of detention, he stopped taking it. And so he's felt like these symptoms are coming back. While in Bernalillo County detention, the folks who are incarcerated there have access to medical services and psychiatric contact, which is great. But the difficulty is that often they then don't have a medical home to go to. We built the Adobe program largely to create the kind of safety net medical home so that when youth are released from incarceration, we can begin to fold them into a comprehensive care model. He has used heroin by injection, and so he's not sure about other conditions that go along with heroin use, like having HIV or hepatitis C. The good news is that he has no history, thank you so much, of heart valve infections. So that's his story. You can see that what we're trying to think about is beyond the substance use disorder, sort of the comprehensive care issues for Antonio. So in the next slide, we begin to think about what opiate induction looks like. So if I don't know if you all would flash a signal or something if you understand heard about induction. If not, I'll kind of go through some of the components of that. Okay, well, thanks. So opiate induction is part of the planning for treatment. And it starts with thinking about the environment that the young person lives in. In Antonio's case, he's living with his grandmother. And we want to establish a baseline for what his substance use has looked like. So his initial drug screen confirms the presence of opiates, methamphetamine, and marijuana. So it's not just opiate substance use that we're talking about, but it's a more complicated pattern of use that we want to be aware of. In part of our provision of care, we ask patients that we take care of sign a contract to receive treatment, which includes items such as acknowledging that we'll do urine drug screens in clinic at the time that we see patients, that will want to be responsible for the prescription, and that patients will not access controlled substances from other sources than our clinic. When we think about doing induction, it usually requires people to go through a brief period of withdrawal so that the buprenorphine component, when it displaces opiates in the neuroreceptor systems, don't cause severe withdrawal. So on the left-hand side of the slide is a picture of a pupil, and that individual's pupil is quite dilated. And when we start induction, we tell patients that they should wait until their pupil achieves that size of dilation, meaning that they're in some phase of withdrawal before they start their first Suboxone dose. The standard approach is to provide patients with a handout so that they know what they're doing. But we create a point of access so that if the patient's having trouble with their induction, they can reach out to us and talk with us about how they're doing. The starting dose is 16 milligrams a day, which is basically in standard dosing 2 of the 8 milligram films. We set up a follow-up appointment in 7 days because we're really committed to doing this treatment in a way that allows the patient to have close contact with our medical team. Next slide, please.
It's doing it again. I'm so sorry.
No, that's all right.
I'm just gonna, let me stop and then start again.
Sure. I just wanted to show you all a standard instrument that we use to assess the severity of withdrawal for a patient. It's called the Clinical Opiate Withdrawal Scale. We use that either directly presenting it to the patient or evaluating them clinically so that we are objectively treating the right thing. And the withdrawal scale basically goes over some of the common symptoms of withdrawal to provide us with the appropriate supporting information to start induction. Perfect.
Is that perfect?
Let's
Okay.
go to that slide. That's perfect. So, so once we start talking about starting induction, then what we find in our patient population is that patients run into barriers. In Antonio's case, he runs into a barrier where he goes to the pharmacy, and for whatever reason, the pharmacy won't give him the prescribed medication. And we see this happening quite often. It could involve that the patient's particular insurance doesn't cover the medication type. So some insurances will cover film, which is a little strip that's placed under the tongue, and others won't and will only cover tablets, which is similarly placed under the tongue. The preparations are essentially the same. It's just that the vehicle is different, and there's different pricing apparently from the wholesalers. Sometimes the pharmacy won't have the medication available, and so they'll tell the patient that they can't pick it up, which is in some sense a tragedy, because in as much as there are not enough providers to try to treat people, it becomes complicated when pharmacies don't have the capacity to give the patient the appropriate medication. And sometimes, and this is really interesting, the lack of a government issued identification form creates a problem. So if a patient presents to the pharmacy without a driver's license or without other identifying information, the pharmacy will not allow them to pick up the medication. Now, the good news is that they generally apply this principle to the pickup of other opiate drugs, but for a lot of the young people we take care of who've had their identity stolen or had their identity lapsed, becomes a real problem. So even though they want to start treatment, they can't pick up the medication. In addition, going to a pharmacy to pick up medication usually requires transportation. And so Antonio can't go there until the grandmother returns from work. His appointment for his follow-up is also up in the air because of transportation issues. And so our navigators work with patients to try to connect them with Medicaid transportation to get them to clinic. But I don't know if all of you know this, but depending on which insurance you have and which ride service you use, it varies a lot in terms of requirements for how many days in advance the ride company needs to know about the patient's appointment, and it also varies in reliability. And then finally, there are problems with access to treatment and counseling. In most cases, getting access to a counseling service is often a 6-week gap. And in terms of getting to counseling, particularly in the pre-pandemic days, it required a way like transportation to get to the appointments. So the navigator helps Antonio by accessing bus vouchers so that he's able to get from his home to the setting. In the next slide, we want to talk about conditions that go along with opiate use disorder. Now, if it were only opiate use disorder, it would be challenging to help people because it's a difficult behavioral pattern and it requires comprehensive care. But people who use opiates often have disordered sleep, partly because chronic opiate use disrupts the sleep center. And so people, as they are going through withdrawal or they stabilize on opiate dose, find that they have very disrupted sleep. They also have restlessness, and often a condition like restless leg syndrome accompanies the initial stabilization. As Dr. Davis mentioned, in the context of adverse child experiences, people have a greater prevalence of psychiatric disorders. And for the youth that we see coming out of detention, their psychiatric disorders are sometimes diagnosed somewhat inconsistently, and they come to clinic with a whole list of medications, some of which don't seem to make sense taken together. And in some cases, they come to clinic without having a diagnosis, even though they've been disturbed by things, for example, psychosis, for some time. And then finally, there's the presence of PTSD, which plays a role in relapse events. Often we hear people saying that they use before they go to sleep so that they won't have bad dreams that have bothered them for years. And so this recurring nightmare situation can play a role in risk of relapse. Next slide, please. So the final step in our process is that of trying to stabilize. And so we see Antonio in clinic. He has started his prescription. When they come to clinic, we ask him scaling questions related to related conditions. For example, we ask him about sleep issues, depression, anxiety, craving, and withdrawal. And when we talk to him about that, he says that his sense of craving and withdrawal are still fairly high, even though he's been on the starting dose of 16 milligrams a day pretty consistently. So based on the patient's observation of their own withdrawal symptoms, we are likely to step him up to the next level, which would be 20 milligrams a day or 2.5 films a day. His urine screen shows presence of buprenorphine, opiates, and marijuana. And so while we're concerned about continued relapsed opiate use, we also know that the buprenorphine has been helpful in terms of beginning to stabilize opiate receptors. And in fact, over the course of time, what many patients tell me is that they will have heroin left over and they'll decide that they should use it. I guess, it's the whole thing about trying not to waste something you've spent money on. But then they'll tell me afterwards that they didn't really feel high and they feel like they wasted their money. So that's an indicator that the buprenorphine did what it was supposed to do, in that it binds the opiate receptors more tightly and prevents opiates from having access. So things are not exactly perfect, but making progress. There's also no methamphetamine in Antonio's urine at this visit. And so we increase the prescription and plan to see him back in another week. So a week later, Antonio comes in and he says he feels much calmer. And the scaling questions look improved. His sleep is better. His craving and withdrawal are down from a level of 3 down to a level of 1. He's still feeling somewhat depressed and anxious, but he feels that the dose where he's on, the 20 milligrams a day, is a good dose. And his urine screen in clinic shows presence of buprenorphine and marijuana. He says he used heroin once after we saw him and didn't feel anything. Then he mentions that his girlfriend, Angel, takes oxycodone. And he's worried about her and her risk for overdose and asks if she could come into Adobe Clinic. Well, our philosophy is that anybody around Antonio who could affect his ability to continue on stabilization is somebody we would like to help. And at the very minimum, what we'll do is send a prescription for naloxone for Angel, so that if she were to take a overdose, that we could rescue her, or Antonio could use a naloxone to rescue her while we set up an appointment for her to come in to receive help. Next slide, please. So after the induction phase in the stabilization process, we get to see Angel. She is also concerned about what the opiate use means for both of them, and she starts taking buprenorphine, and they come as a couple to biweekly appointments in Adobe. We begin to talk about chronic medical conditions, and they agree to be screened for infectious diseases like HIV and hepatitis C. We have a separate conversation with Angel about her reproductive future, and she agrees to accept long-acting reversible contraception. She and Antonio feel that they're not ready to become parents. And of course, we're very pleased to be able to provide that kind of care. And then Angel has medication for depression that's helped in the past, and she agrees that we should restart her antidepressants. So we've felt like we've made some progress on the medical side as well as longer term medical progress. This slide in the background is a guy who has basically learned that technique of taking your t-shirt off, whipping it through the air and catching air in it so that you can use it temporarily for a flotation device. And in some ways, I think Dr. Davis and I agree that the starting of medication-assisted treatment is a bit like giving somebody a life preserver in sort of the existential deep water. And while that's fine, it keeps people from sinking and drowning, there needs to be more. And so our navigator is working with the couple to help them find stabilized housing. And so they get assistance with making a Section 8 application. We have education specialists who they meet with, and Antonio starts working on a GED, and Angel has been out of school for about 1.5 years. And so the liaison assists her with identifying the appropriate school, and she gets enrolled, and we start that process of trying to stabilize education. Next slide, please. So the process after stabilization is begin to help people with the concept of recovery. And in this slide, although it's a little hard to see, we have a gentleman in a pretty significant wave who is starting to swim. And that recovery process is a little bit like going from having a life preserver to starting to make that sort of daily effort that moves people toward a safer and healthier place. And so, as Dr. Davis mentioned, we really believe that there has to be a combination of medication plus counseling to get the best results. And sort of think about it like individuals who've had adverse childhood experiences have these chronic stresses, often that have not been addressed in their earlier lifetime, and to some degree they self-medicated. And if we can connect them with the right kind of counseling to think about what that stress looks like in their life, when the situations come up again, for example, they encounter a parent they haven't seen in a long time, how will they continue to stay stable? We think that plays a lot of role in the idea of relapse prevention. In addition, consistency in education and employment are a big part of being in recovery. That kind of need to get up every day and go to work and deal with the challenges of managers and the daily routine, while challenging, is what we would think of as a tolerable stress. I mean, look at all of us. We're all trying to manage this tolerable stress of living in the pandemic world and keeping things together. And similarly, what we hope is that the young people we see get the right kind of support to do it. But unlike those of us who have the capacity and the life background that allows us to do this pretty competently, a lot of the young people really don't have role models that have helped them understand how to do it. Finally, after 9 months to a year, we begin to talk to our patients about whether they are on the right dose and whether they want to think about reducing their dose. Some folks want to stay on stable dosing for years, and I've taken care of people on stable dose of Suboxone for 3 or 4 years. That's fine. They're functioning. Things are great. They're doing a great job with their kids. Other people want to go down on their dose. And basically the way we set this up is, as Dr. Davis said, we do not have any financial conflicts of interest. And we do not intend to keep people on medication for the rest of their lifetime if they don't feel they need it. So the patient has complete control over it. They'll say, well, I want to try a lower dose. And what we'll do is give them the same prescription they had, give them instructions to, for in Antonio's case, for example, take only 2 films of Suboxone a day so that he's reducing his dose by 4 milligrams. And after a couple of weeks, if he feels stable on that, then we'll move him to a prescription for 16 a day. And after another couple of weeks, potentially go down by another 4 milligrams. But we want the patient to feel like they're in complete control of this process. And we're continuing to monitor their scaling questions relative to issues of anxiety and depression and sleep. And then once we get through the process of medication-assisted treatment, the next goal is to make sure that we help people move into process of long-term continuity of care. And so the goal is to provide them with a warm handoff to ongoing primary care and maintain counseling, because these, in the sense, are chronic health conditions that we wouldn't anticipate going away. We would never tell somebody whose glucose we stabilized with insulin pump that they're fine and they don't need to have ongoing care or monitoring because we know that the risk of severe illness and death are still quite high. So the goal after we do our role in terms of supporting medication-assisted treatment is to do a warm handoff to ongoing behavioral health, psychiatric, and medical care. So that's sort of the mechanics of how we think about providing medication-assisted treatment in Adobe. And I think that comes to the end of my slide presentation, and we would be very happy to respond to questions.
Thank you, Dr. Shi. That's actually perfect timing. Sometimes we have people who need to leave us at noon because, I mean, at 1 o'clock because for court dates and whatever. So I just want to remind any of you that need to leave to please do fill out our post-session survey. It is an integral part of our program's data collection efforts under the federal grant. It'll only take a few minutes of your time. Jen has posted a link in the chat and can put that up again. So I just want to remind you to do that. And then then we still have about 20 minutes for questions and answers.
If I can find that, Leslie, this is George. If I can find that initial question that I didn't answer, I'll go back to it, but I guess there's other ones coming in.
There are.
Yeah.
So if you, I think Nita was the first one. Nita, if you want to go ahead.
So thank you both for presenting this information. It's been very helpful today. I just had a question about in the termination phase, if you let's say, for instance, if you were to change the hypothetical of Antonio to you started reducing his amount of Suboxone and you're titrating him down, what if he were to go back to relapsing because of other events, how would you handle that? Would you talk to him about maybe not titrating down? Would you up the dose and maybe consider that titration is going too fast? Like, just what would your kind of recommendations be if the scenario was a different hypothetical?
Oh, sure. Thank you so much for the question. Yes, at every visit, we're doing urine drug screens. If we start seeing presence of opiates again, then that leads us to a conversation with Antonio about how's it going and what do you think is happening with the opiate use? And well, he may have gone to the ER and had a hurt arm and they gave him a prescription for oxycodone or hydrocodone for a few days. Oh, that's great. Let's take care of your arm as well. If he feels like he's at risk of reusing heroin, then we would begin to think about working with him to increase the dose of Suboxone to get him to a place where the issue of craving goes away. So none of this is, usually it's not a linear process. There are kind of peaks and valleys, but we don't dismiss people from the program for relapses because we think that maintaining that relationship and ongoing care is really important to their long-term recovery.
And I just want to second that too, is that's what Dr. Shi just said. The program, the way it's done, is so forgiving and so self-directed that it doesn't have a punitive aspect, which is, I can't emphasize how important that is. It was to witness that the first time was amazing to me.
Thanks. Okay, I think Gail was next. Gail?
Thank you both very much. It's very interesting and I think useful. I think the thing that concerns me the most is the fact that you indicated it's not, you really don't have enough resources and so forth to make this available to everyone who needs it. And I guess I'm wondering how exactly how it's funded and what you need to do, and how we would get it into the rural areas as well.
Dr. Shi, I'm gonna let you start on that because it's a hard question.
So thank you very much, Gail, for that question. So I think it's a three-part process. One part of it has to do with the fact that a lot of providers in primary care and say in particular pediatrics don't really feel that they have the bandwidth to provide medication-assisted treatment for young people with opiate use disorders. And I have to say, in all honesty, when I started pediatrics, I really had the idea that I would not really want to deal with these issues, and I was going to take care of cute little kids and pat them on the head and everything would be fine. And, you know, as a native of New Mexico, what I realized fairly quickly was that it's an all hands on deck kind of effort. So if we put in, for example, the treatment of opioid use disorder as part of the residency experience, and the medical students and residents rotated through clinics that are able to do this, I think their comfort level would go up. A second element of that is really the issue of the challenges of trying to provide medication-assisted treatment without the appropriate support services. So our program's funded through behavioral health funds from Bernalillo County. We have been able to use that funding to build our navigator and education team. And I think if I were in private practice without those kinds of supports and without having access to psychiatric support, it would be impossible. The tragedies of trying to take care of people without appropriate supports would be immense. Thirdly, New Mexico is in prime position to expand to rural areas because we have Project Echo and we have potentially a very robust infrastructure for 5G that the current administration is supporting. Now, it doesn't mean we have to have a child psychiatrist in every community in New Mexico or a primary care doctor who is committed to treatment. What it means is we need to find ways of connecting people through technology and, for example, hiring navigators among people in the local community to do some of the work that our navigators do here in Bernalillo County. We have tried to get money through the legislature to expand to rural New Mexico or even contiguous counties. And that hasn't happened. And everybody agrees that we want to reduce and prevent youth crime. But getting to the issues of how we do that, the kind of nuts and bolts of getting it done, still seems to be somewhat elusive.
Thank you. We should talk later.
Happy to.
There is another question from Kristen Conley. She's asking, how hard is it for a general practitioner to get the proper licensing for prescribing for areas of the state with few resources?
Go ahead, Andy. I can start it, and we'll see if you want to add something to it. It's not that hard to do. I mean, it's an 8-hour. Well, for MDs, it's an 8-hour in-person, well, now it's probably online, but course, it is online. Andy's giving me the signal at this point. And followed by a test, which just assures kind of mastery. And then, you know, the real thing is, though, doing that, taking that course and taking that test doesn't really complete the training. You need to work with someone who's been doing it for a while. I can tell you, I can pass a test, but I still didn't know what I was doing until I got into that clinic. And so it's not that cumbersome. And I noticed in the LFC report that I read on substance use, came out in like last year in 2019, they thought that was an impediment. No, I mean, I think it's important to have people that are well trained and feel competent, and I don't think it's that burdensome.
I would just second what Dr. Davis said. I mean, we don't require practitioners to take any kind of test or training on the use of opiates or prescription narcotics. And so part of the reason we have a problem in New Mexico is that is that people believe that giving immense numbers of opiate prescriptions is a way of maintaining patient engagement. So the good news about taking the training for the exception license is that a lot of the training also involves appropriate pain medication prescribing, which I think would be valuable to every provider.
Yeah.
Thanks.
And Gail had a follow-up question that she's asking, what was the specific impediment according to LFC?
There's actually quite a useful report and pretty well written. as you might know, is probably one of the best readers of an LFC report. But the impediments, they just listed that as though it were something that was an obstacle, or at least a speed bump in promoting it. And it's not. I don't think it is that much of a speed bump. The other thing are simply just the access of providers, period, and interested providers. And Dr. Shee's right. Like when I was looking at one of the primary places where you would want to do this is in detention facilities. And there's very few detention facilities that are doing it around the state. And sometimes it's simply the preference of the provider, because there's still a lot of bias about this. People say, no, it's just supplanting one addiction for another, which it clearly is not. And so that bias is usually just a degree of education. But I think providers in general is another obstacle.
I'm still missing the first, I'm trying to take notes, even though we're going to get the slides, but this is a discussion part. So I still don't know. Did you say there are not that many providers that buy into it? Is that the impediment you were discussing that the LFC put in the report?
No, they put in there just the fact that people needed a specific certification.
The certification was the impediment.
Yeah.
Okay.
Yeah, they thought the certification it was a minor comment.
Okay.
But the certification is, in my own opinion, necessary and not that burdensome. And oftentimes it's a matter of providers encouraging them to get that certification. And it is true. Treating individuals with addictions, I think there's always stigma around that. Whether it's even in the providers, I think there's stigma. And time usually handles that, and exposure usually handles that.
Thank you.
Nita, did you have another question?
I did. And this is going to be kind of a multi-part question, but before I ask it, I just wanted to perhaps one of the things that might help with that stigma and reducing the amount of practitioners who aren't interested in it is somehow tying federal funding to increase the rates of reimbursement from Medicaid and Medicare to doctors who actually do that. That's just kind of a cerebral out there thought, given that money can be a big motivator. The second question I had was, when you have clients, or if you've had clients who you suspect might have a traumatic brain injury, and how does that act with this type of work that you're doing? Because, for instance, like we might have clients who are victims of domestic violence, or just have had really rough pasts where they've had lots of hits on the head or something. So my question is a little bit multi-part in the sense of, how does that intersect with this type of treatment? And if you do suspect a TBI, what is the, I guess, respected practice, and how do you diagnose that for certain? And where do you send that client for that diagnosis?
You want to start? Go ahead.
Well, thank you. There are certainly a lot of people who've had head trauma, and in that and multiple body organ trauma. And so one part of that is to make sure that we have a clear history to the degree that people can tell us or remember. A second part of that is the access to neuropsych testing. The fact that somebody has a brain injury in and of itself could have various manifestations. Oftentimes trying to access neuropsych testing to understand what the range of their potential disabling conditions are is a challenge. Once that is done, that leads us down different diagnostic or different therapeutic pathways. A similar issue occurs when we are dealing with individuals who have special education needs, who have intellectual limitations, and their understanding of how to participate in counseling or treatment services. So that's an ongoing and challenging issue, and it also really interfaces with the issue of law enforcement. I mean, it is not quite clear to me that throwing somebody who has mental limitations and a head trauma into jail is going to convince them that they shouldn't act impulsively in the future. So I think there are a lot of different ramifications of the question you asked, and thanks so much for your thinking about it.
And some of those are medical too, meaning maybe if a person with a head injury, that's kind of a very broad term because there's something specific about that, but it can affect, not only motivational and impulsivity, but it can affect the effect that the different medications that the opiate replacement therapy would have. There might be changes, but there's nothing that specifically contraindicates it, and it can relatively easily be managed just with additional caution.
I'd like to say that I think finding prescribing doctors or encouraging people to get the appropriate certification would be a good place for judicial leadership. And I think there could be leadership from beneath by attorneys going to their judges, asking judges to contact doctors in those outlying areas. I see a few people that are in this meeting that practice outside of Bernalillo County, and that might be a way to ask your judge to contact doctors in the area to see if they could come up as a resource.
Also, the medical school, a lot of residents pass through the clinics that Dr. Shi is in, and that familiarity sort of reaches a more of a critical mass when you get training around it and watch it as well. But I really agree. I think it's a good place to start, frankly, is more providers doing it.
The Family Community Medicine Residency Program has been terrific in training its residents on the management of opioid use disorders. And we're turning out 8 to 10 residents a year, many of whom are staying in New Mexico, who have this ability. And it's just fabulous to watch them in practice. But another part of that is that often providers don't get a chance to stay with patients and families long enough to see the beneficial effects. And so part of what makes what we do possible is that we certainly have patients and families who don't do well, and those are heartbreaking. But because we have navigators and educational liaisons working with us, we also get this incredible opportunity to participate in the developmental trajectory of families. And that is just so encouraging and is the positive motivator to kind of keep going with it. So building those kinds of networks in for providers and for communities changes the idea that people who have addiction can't change. And once we can kind of win that, I guess, that battle of knowledge, then I think we have a much better chance of helping people.
Thank you. That actually is a perfect place to end on because that's exactly the battle that we have, is convincing the courts and others that our clients deserve that opportunity to get this kind of treatment and get long-term help to address their needs. So that's actually a perfect place to stop. We are at 1:14. Thank you so much, Dr. Davis and Dr. Shi. It's really wonderful. We appreciate your time and assistance with this. For everyone, the PowerPoint will be in PDF form in the resource library for NMFAP ECHO. Want to remind everyone again to fill out the post-session survey, and Jen has put the link in the chat, I think, a couple of times now. Please remember that. Also just want to remind everyone our next, so we're heading into the holidays, and then we have CLI in January. So our next NMFAP ECHO didactic session is not until February 16th. That will be, the topic will be SSI and the DD waiver for families in the child welfare system. And so we hope to see you back then. We also want to encourage all of our practitioners to send us ideas, questions, issues that you would like to see presented in these trainings. And that is all I have. So again, thank you very much, Dr. Davis and Dr. Shi.
Great.
Thank you. Very nice to talk to you guys.
Doctors, thank you, everyone else.
Thank you very much.
Thank you very much.
Welcome.
Thank you.
Welcome.